Welcome to the Learnskin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Our skin is our first line of defense, our largest organ, and a major component of our physical identity.
It plays an important role in our health, psychology, and how we connect and relate with those around us.
So join us as we delve into the art and science of skin health in today's episode. A short disclaimer before we get to the good stuff. Dr. Raja Sivamani and Dr. Hadar Levtov are board-certified dermatologists.
Yes, we are.
This podcast is meant for educational and informational purposes only. All opinions shared do not express the views of Learn Health, Inc. Neither this podcast nor any information contained within it are a substitute for professional care by a doctor or other qualified medical professional.
Absolutely not.
This podcast does not constitute medical or professional advice or services. If you have a medical concern, please consult with your physician.
Hey, Raja, how are you today?
Hey, Hadar, I would say COVID kind of mood today. I mean, it's a little bit down, staying isolated as much as we can. But, we got some good things to talk about today.
Oh, absolutely. And I think we are social distancing. I'm all the way here in Florida, and look at you all there in California. I mean, I can't think of a larger distance, huh?
Physical distancing, Hadar, physical distancing. We're socially close.
Alone together, absolutely. And today I think we wanted to talk about psoriasis because it's such a prevalent disease that we see routinely in our clinic, and anybody who takes care of people with skin problems must see that as one of the most prevalent skin condition. And there's a lot of therapies for psoriasis, thank God. But with more therapies come more questions. And now we've been kind of thrown into this COVID-19 world where we have to adjust our management. So I think we're in need of an expert here.
Yeah, we definitely are, because we have to think through these immunosuppressive treatments and immunomodulatory treatments. So we have Dr. Jason Hawks with us. He is a dermatologist, and he's done quite a bit of research in the psoriasis space. And he is on the faculty at UC Davis and sees patients clinically, takes care of these patients, and he's also on the board of the National Psoriasis Foundation. Jason, welcome to the podcast.
Welcome.
Thanks, Rajadar. I'm glad to be here.
Yes, and we should say that you're recording this from a socially distant place.
Yep, still sitting here in the office, so I'm away from everybody else.
Exactly. So perhaps we can start by you telling us the National Psoriasis Foundation came out with these guidelines, and why should we have guidelines to begin with? Why is it important, and why is it important under these circumstances?
And Hadar, you're referring to guidelines in relation to COVID-19, right?
Yeah, exactly those.
Yeah, really, the National Psoriasis Foundation, was really responding to the questions that came from patients that, as these patients have, psoriasis or on these different medications that they know can affect their immune system, it raises the question, there's this infection, they've already been told they might be at increased infection. And, I think the physicians on the medical board, as well as the faculty, were just started getting bombarded by questions as to now what do we do? We're at high risk and we might get this infection. Should we stop our medications? And I think in the absence of data, as we're all kind of trying to understand this pandemic as it unfolds, the need for guidelines there is really just to say, based on what we know, this is what we think you should do. Or, these are the experts getting together and saying that, this is what we think is the best approach for you. And those guidelines are important because it's going to take, months or years before we fully understand the sort of immune impact that coronavirus has as we collect data and samples. And there's just not enough time to wait for that because there's fears now, there's questions now. And the guidelines are exactly that. They're a guide until we get to that time point where we have more data.
Yeah, thank you for mentioning that, because I think two key things that you are noting here is one, that this was really driven by patients, and I think Raja will agree as well, and any doctor walking down the street right now will agree that patients are calling with questions, regardless of what you are treating, what kind of doctor you are, what kind of patients you're seeing. Everybody has questions about what to do. And the other thing is that this has some limitations. So these are best understanding of what we know right now and how we can move forward in a practical manner. This is driven by some data that is known, but certainly not specific for COVID-19, right?
Yeah, and I think the other piece of the guidelines is that it also gives a platform for, those of us that are intimately familiar with the disease to put our position out there and say, based on what we're seeing and based on our experience with for years with these medications, this is our stance. This is where we feel we should be moving or how we should be managing these patients. And so I think this is one, let's respond to patients. Two, we don't have all the information, but we feel strongly about moving in X direction.
And I think those are posted on the National Psoriasis Foundation website, which is psoriasis.org, and we'll post that link in combination with this podcast. So let's jump into it, because I think the first few are really reasonable and kind of talk about how you should approach this when patients come in to you and ask you questions, right?
Yeah, these are very straightforward. And I think, the first few points here are probably the most evidence behind them lies in these first few points, which is that we know that with infections, the CDC guidelines and the World Health Organization and federal and local guidelines are really the thing that are going to help prevent the spread of infections. And we wanted to make that very clear. I think I'm not necessarily speaking for the National Psoriasis Foundation, but I think in these guidelines that these groups are coming together to say that these are the things that we know are tried and true against infections to prevent the spread.
Right. And I think some of those specifics from the CDC and other authorities is what we're actually doing right now. Social distancing, washing hands, watching for cleaning surfaces. Right, Raj? I think you had a great point about that the other day.
Yeah, and we'll come back to the cleaning surfaces. I think it'll be nice to talk about that at the end. There's some nice studies looking at how long COVID-19 actually lasts on different surfaces. But going into the guidelines a bit more, and I think, the point about telehealth appointments whenever possible, I think that makes a lot of sense. And then as we get a bit more into the meat of actual treatment and therapies, one of the things that I thought was interesting and would like to have you comment on is that if an individual is not on immunosuppressive medication, the idea is that they don't have any additional risk just because you have psoriasis. Jason, can you comment on that?
Again, it's sort of this idea that, psoriasis, even though it's a chronic immune, activation, that we really don't view those patients as necessarily by virtue of their disease having increased risk of COVID-19. At least we don't have any data that suggests that. We've got a really prevalent common disease, and we're not seeing patients who, are preferentially being infected who have psoriasis, for example. And, I think something that's interesting about this condition is that it's an overactive immune response. And one of the things that we clinically see, and both of you have seen this, that, patients, if anything, tend to be more protected. And that's true in a lot of clinical scenarios, like comparing it against eczema or atopic dermatitis, where you have a condition where it's chronically prone to infections. We really see a resilience in individuals with psoriasis, and they really aren't chronically sick relative to the general population. So I think it stands to reason that these patients aren't necessarily at increased risk just by having the condition. Now, that doesn't mean that patients with psoriasis who have other comorbidities aren't at increased risk. We're saying just an individual that's healthy versus an individual that's healthy that has psoriasis.
So you're referring for comorbidities like diabetes, for example, that was suggested to have an increase in severe outcomes due to COVID-19 infection, right?
Sure. Or, we see psoriasis patients with, they can have sleep disorders or pulmonary problems. And, a patient with psoriasis who also happened to be a smoker and had COPD or emphysema, obviously they would be at increased risk, but that risk isn't derived from their having psoriasis.
So, Jason, this is great that we're talking about folks that aren't on therapy. Now, the folks that are on therapy, the shooting from the hip reaction would be, let's just pull them off of anything that's immunosuppressive. But one thing that I thought was very interesting in the guidelines was that it's not recommended that all patients just immediately stop biological therapy, and that there was a bit more nuance to that. Can you speak to that? Because I think that's the question that a lot of folks are asking is, what do I do with my biologic therapy in this environment?
Well, I don't think it would surprise any patients or even physicians of all specialties that making a one-fits-all recommendation is almost never advisable, right? So the reality is that people have their disease severity can be different, their age group can be different. where they're living can be different. For example, you have a patient that if a patient has been through 9 biologics and finally find one that works, then the risk of potentially stopping that medication or losing its efficacy by stopping it and not being able to regain their disease, that's going to be a much higher risk than a patient who's only tried one biologic and has all these other options still available to them. And so the point here was really to not say that there's one recommendation is going to be applicable to all patients. I think medicine has always been a personalized approach. And I think as we get better at uncovering the pathophysiology of these diseases and having these targeted therapies, that we always want to approach healthcare in a way that's evidence-based, but also driven by, what's best for this patient. And in the same way, a blanket statement to just stop biologics for all patients, I think is going to result in harm in some patients.
So I have a scenario for both of you, and this is not an uncommon scenario. Say you have a patient, psoriasis, on a biologic, no symptoms whatsoever, test positive for COVID-19, has no symptoms. And we know that there are many folks that are younger, don't have any symptoms. In the setting of no symptoms, would you stop the biologic for someone that tests positive for COVID-19? And the reason I ask is there any role in the biologics preventing COVID-19 from becoming worse of an inflammatory response once it takes hold? What I'm really asking is about intra-infection management rather than, prior to infection. I'm curious what both of you think about that.
So I'll take that first as general comments, and then the specific Jason probably can give us some more wisdom here. And that relates to comments I wanted to make about what Jason said before. So there's a practical issue here because the half-life of some of these medications is so long. Some of these we inject every 3 months. So it may be a point that's not really worth even discussing because they may have injected a week ago and that's it. It's in the system. So that's something to keep in mind as we go through this. In general, my approach would be to keep them at home, monitor them. If they have to take a dose right now, then we know that when you have an infection, in many of these, it's contraindicated and not advised to use any of these medications. And so that, to me, would be that approach to skip a dose if a dose is coming up.
Yeah, and Hadar's point is an important one, is that this really comes down to timing. As was mentioned, patient may have just done their injection for their psoriasis and 4 days ago, and if it's a medication that's dosed every 3 months, then it's a little bit of a moot point here, because if they get an infection, you don't have to do anything. It's not like a medication that they're taking every day. And so I think here, what my general feeling here is that if a patient were on the other end of that, where I have an injection in a week or 5 days, what should I do? I would recommend that they hold that medication. And to sort of answer your second part of the question, Raja, which is that, is there evidence that their biologic may be helpful? And it's really one that just the bottom line is that we don't know. That's the most important thing, is that we don't have any evidence to suggest that it's going to be protective or harmful. But I think in terms of patient care, we have to err on the side of patient safety. And I think that there's still a potential that it could make it worse. And part of that is the medications are going to blunt the immune response. And what we don't want to do is hamper the body's ability to fight off this infection. And I think that's the primary concern. In the absence of other data, we have to sort of err on the side of giving the body the best chance to fight back against this infection. So my general recommendation to patients in this specific scenario would be that if your dose is coming up and your skin's doing pretty good, then let's hold the medication and give your body some time to get over this infection. And one of the advantages to the biologics, from my perspective, as opposed to medications where you're taking on a weekly basis, say with methotrexate, is that they tend to last longer in the system, even beyond their half-life. So there are many patients that they've done an injection and maybe it's due in 3 months. If they were to wait a month or two, there are many patients that their skin remains clear. So from the standpoint of disease that's well controlled, there's probably not a lot of harm in stopping that with regards to their underlying psoriasis. And so I do think holding the medication right now until we have more information about whether it could be helpful or harmful is probably the safest way to err in terms of the patients.
Clearly a nuanced situation. And thanks to both of you for kind of taking us through your thought process.
Yeah, but I think it's going to become an issue, Raja, and I think it's a great question.
Yeah. And then, so on that note, actually, in regards to these medications, are all biologics created equal? Or do you think of them as having different risk stratification based on how they act? And Jason, what do you think about that? Do you think that all the biologics should be kind of lumped as one group, or how do you think about them?
Yeah, it's a great question. And there's a lot of anecdotal evidence and people sort of sharing their opinion about which class is safest and which ones put you at higher risk. And again, we really don't know, but we can think through the biology of where these agents act and how they work and sort of get some understanding, at least think through how being on that medication could potentially be better or worse than another class. And I think in general, we've always thought about the systemic immunosuppressants, oral medications such as cyclosporin, methotrexate, as acting very broadly in the immune system. So the impact on the immune response is going to be a more drastic immunosuppression. And as you move up from the systemic immunosuppressants, I think about the TNF inhibitors as being still broad, but not as broad as the systemic immunosuppressants. So in general, those two classes, the methotrexate, cyclosporin, and the TNF inhibitors, are going to be a higher risk by virtue of their broad effect on the immune system. And the advantage to the newer agents, Solara, which is going to target IL-12 and IL-23, and then the class of the IL-17 medications, and then a similar class, the IL-23 antagonists. Those agents are going to be more specific. So I describe it as patients as being, you can either be on a bomb that blows up everything in the immune system, like the systemic immunosuppressants and the TNF inhibitors, or you can be on something that's maybe a little more like a shotgun or a sniper rifle, right? They're getting closer to hitting the piece of the immune system. And I think, again, as a general concept, that the more targeted agents, these newer agents that are hitting a smaller portion of the immune system, would theoretically be a better agent to be on if it controlled your disease and allowing the rest of your immune response to effectively function like normal. But there's an even deeper level to it, which is that it sort of makes an assumption that the drugs in each of these classes are the same. And we know that from the clinical trials, while they perform similarly, they're not exactly the same. And that isn't a big surprise, given the fact that these are not the exact same drug. So it wouldn't be unreasonable to think that a particular agent in a class might have some differences from another agent in the same class. And I think from that standpoint, we also have to be careful to not make recommendations about a class as a whole, because we're talking about 2 or 3 different medications which aren't identical and haven't been studied in the setting of coronavirus.
That was wonderful. Thank you, Jason, for that insight. One of the things I wanted to mention, we may have not mentioned that in the beginning, but and it may be stating the obvious, but these medications treat a condition that's pretty severe, and some listeners may say, you know, who cares? Just stop the medication. It's a rash. And so, just to remind our listeners that by definition, if you are on one of these medications, you have moderate to severe psoriasis, which can be pretty devastating. And I'm not even talking about just the rash itself. Literally, some patients with erythrodermic psoriasis can be in a life-threatening situation. But more than that, for the masses of people, quote unquote, who are on these medications, a flare of disease brings them to a dermatologist's office or to another practitioner's office. And that by itself increases the risk of spread of COVID-19. And so this management is not that simple. There's another layer to that, which is the public health management situation.
I think it's a very good point, Hadar. And I do want to add a nuance in here because, I have a patient that's in the same situation where the arthritis is really bad. And so it's not just the psoriasis, but the arthritis, and they are on a TNF inhibitor. And we had a very detailed conversation, and they are hunkering down at home. We had the visit by video. And can you believe it? The insurance company has made a blanket statement. This is one of our managed plans. It's a Medi-Cal plan, has made a blanket statement saying, oh, in the era of the environment of COVID-19, we are now going to deny all biologics refills. And so I actually had to get on the phone and just educate them that if we do that, and you have a patient that's going to have a horrendous flare of arthritis, they're going to end up in the ED. And then you may be covering a COVID-19 infected patient rather than just someone that's at home, just doing their thing, staying physically distanced from everyone and making sure their psoriasis is under control. So again, going back to what you're saying, Jason, there's these nuances that we just have to pay attention to when it comes to even these bigger biologics, like these more broad biologics. Sometimes if they're staying at home and doing all the right things, it is the best way to treat them and not put them at risk for having to come out and end up in an urgent care or emergency room facility.
Yeah, and that's a good point. Both of you kind of feed into an area that I've been thinking a lot about, and just sort of formulating my own response to these patients. One of the things that I've spent a lot of time thinking about is this idea that in the interim, when they're off their medication, if they were to flare, what am I going to do? Because not only do they put themselves at risk going to an emergency room or an urgent care, or having to be admitted, for example, a severe erythrodermic or pustular flare, that's one problem in and of itself. But the second piece of this is that we typically use broad systemic immunosuppressants to get them under control. For example, cyclosporin would be used in a severe pustular or erythrodermic patient, in the absence of infection to help get them under control. And again, that has a very broad effect on the immune system. So there is a risk. Could I pose the question that say, so what? Let's just stop the medication and then everybody's safe. But it's not that simple, because the flares have their own risk. And remember that when we treat these patients who have these severe flares, the treatment that they have to go to might be worse than the one that they were on had we just maintained it. And that has to be a consideration. But there's another aspect as well, which is that not every patient responds to a medication that they stop and then go back on. I think with the newer agents, we've seen what we'd call better recapture rate. That is having a disease that's well controlled, stopping it, having it flare, restarting the medication, and recapturing the good success that we had. And those are very good with a lot of the newer agents. But for example, in the TNF group, there are the specific agents that have a high likelihood of the patient developing anti-drug antibodies and that medication not working. So if that's the class that is the most effective for their disease, then you potentially put yourself in a bind in terms of getting that patient under control and needing to treat them, long term or for a longer period of time with a more, a broader acting systemic immunosuppressant.
Thank you, Jason, for that insight. Again, anti-drug antibodies and recapture rate is such an important consideration. I wanted to wrap up this piece on the National Psoriasis Foundation by just mentioning that the bottom line seems to be here that, as you mentioned, it's an individualized approach in many times. And so clinicians, anybody who takes care of people with psoriasis should really review these guidelines to help you think about it. And then when the patient comes in, you can start having a more educated discussion. Also, there's some sources in the JAD who's been publishing very well on this recently, and I encourage all dermatologists. Really, I want to give a shout out to our journal that's really putting out articles in this time. Even though the data may not be fully there, they're trying to help people and avoid paralysis. So there's a good article by Dr. Lebel on BIologics there. Raja, you had some final comments?
Yeah, when we're thinking about our psoriasis patients, we're always talking about how to have good hygiene, either sanitizing your hands with something that's got more than 60% alcohol or soap. And, the CDC recommends 20 seconds of washing. These are all very important to follow. I think it's also important to realize that surfaces can harbor COVID-19. And it's good for us to have a good idea of how long they can live and why it's important to just make sure you wipe down areas, especially if they're in public areas when it comes to surfaces, but also to not overreact. The reason for this, I wanted to bring up an article in the New England Journal of Medicine. And what they did was they looked at how long, it goes under the name of SARS-CoV-2, but that's COVID-19, and looking at what the virus's viability was on multiple different surfaces that were maintained at room temperature and 40% relative humidity over 7 days. They looked at copper, cardboard, stainless steel, and plastic. And would you guys believe, of course, the lowest half-life, which was less than 2 hours, it was like an hour and something, was on copper. So time to bust out those copper cups, everyone. In fact, my wife and I have busted out the copper cups, but, we live together. So, if one of us has it, the other one's going to get it. But cardboard is just shy of 4 hours. So I know people have been concerned about, if deliveries come to the front, if they're Amazon deliveries or whatnot. Really, it's a pretty low amount of time that it's living there. And I think Dr. Fauci made the same comment. It might be an overabundance of caution to worry about deliveries that show up at your front door. Stainless steel is up to 6 hours. This is really important because we touch stainless steel things all the time with doorknobs and whatnot. So it's really important to be aware of that. And on some plastics, it can be up to 7 hours. So if you're in an elevator, make sure, either you wipe it down or use something indirect if you're going to go touch the elevator button. And again, it just speaks to the fact that if you're in a public area, don't be if you can help it, because especially if you're immunosuppressed. But just realize that some of these surfaces can have half-lives that are up to 6 to 7 hours, which means for clearance to get down to something reasonable, it can be over the course of a day or even up to 72 hours in some cases. So I think it's very interesting data, and it puts things in perspective.
Yeah, thank you, Raja. Actually, data is what we need, so anything is useful, right? And I know that just reinforces the whole approach of just stay home, because otherwise you're really running a risk of touching something that you don't know who touched it last and what's on it, regardless of the surface. But at least if you do have things coming to your home, I think that's very reassuring to learn. And I know that we are trying to wipe our doorknobs and such a couple times a day just to make sure that we don't carry things, having to go to the hospital myself. I'm trying to be very cautious of that. So other clinicians who are listening in, these are simple things you can do in your home to protect your families.
Right. And we'd like to thank you very much, Jason, for coming and joining us for this podcast. This was very enlightening. And obviously, it's a nuanced area, but we appreciate your expertise in discussing these points.
Yeah, it was great being here with you guys. Thanks, Raja and Hadar.
Thank you. Thank you for tuning in to today's episode with Dr. Raja and me, Dr. Hadar. This podcast is brought to you by Learnskin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs or subscribe to the podcast today and never miss an episode. Have a great day and stay curious.